push that button, it remains on.
Okay, 30-second warning, please. Good morning, dear esteemed guests. Welcome to this session on AI in healthcare. I am Moira Patterson from the IEEE, and I will facilitate this session. I'm honored to be joined by all of you and by the 4 distinguished experts that we have here today: Steve Soot from Michigan State University, Lili Milani from the Institute of Genomics at the University of Tartu, Dan Bogdanov from Cybernetica, Susan Kaplan from Moral Technology Corporation, and we've also been joined by a government representative from the Netherlands, Thomas Faber. So we look forward to talking about the opportunities and managing the risks related to AI and other technologies in healthcare. The theme, of course, of the conference is AI and public value. So we really want to keep in mind the applications for government and the best outcomes for patients. So the public value theme will be critical in what the speakers will be communicating today. We look forward to engaging with all of you here. We hope that the audience will be active participants. So as you have questions, as you hear ideas that you think are critical to pursue further, please do make note of them, and we will have a question and answer session at the end. We will start with all of our presentations, but we will leave sufficient time to make sure we have questions to engage. We've also been asked to do questions with microphones as this session is being filmed and live cast. So for the other people who are watching online, so that they can hear, please do not ask questions until you have a microphone. Okay, so to get started, I want to ask Steve Soot to be our first speaker and kick us off.
Thanks very much. I believe there are 2 slides that I wanted to, okay, great, there, you can see them on the screen. So this is from a paper in Nature from about a year ago. As I mentioned earlier in the main session, this field is moving forward extremely fast. And what is shown here are 3 different risk predictors for 3 common disease conditions: heart disease, breast cancer, I believe it's breast cancer, and diabetes. I can't read my own slides from here. But now what's shown on the horizontal axis is something called a polygenic score. It's something that machine learning or AI produces after looking at lots of examples of people, so the genotypes and the disease status of many people. And the AI learns, and then it builds a predictor, and then you can run the predictor on data which is very inexpensive to obtain. It's basically the equivalent of a 23andMe type genotype. In your public health system, you could gather these for a cost of about $50 per individual. And once you gather their genotype, you can compute all of these risk scores. There are now about 20 different highly impactful risk scores for common disease conditions, ranging from heart disease to schizophrenia. And these predictors are good enough that you can identify people who are outliers, who are either at very low or extremely high risk for the condition. So what's graphed on the vertical axis of each plot is the odds ratio, or the elevation of risk for an individual. So people who have a high polygenic score, say 98 or 99th percentile polygenic score, they could easily have 10 times or even 20 times the risk of a typical person in the population. To a healthcare professional, this is like magic, right? For a $50 test, you can figure out what subset of the population is most likely to have diabetes, most likely to have breast cancer, and then you can intervene in some constructive way in their treatment. And again, this technology did not exist 2 or 3 years ago. It's only 1 to 2 years old. And the question is, which governments, in the case of a single-payer government healthcare system, which governments will be smart enough to actually implement these things quickly rather than waiting for a long time? Let me just show the second slide. Oh, I guess I do it myself. Okay. Okay. This shows something else called height prediction. So the blue dots are men, the red dots are women. The horizontal axis is the height predicted from genotype alone. So imagine you got the DNA off a gun and you just analyze the DNA and the AI predicts how tall the person was who had that DNA. And the error bars are those black vertical lines, and the standard error is about 2 to 3 centimeters. So you can predict the height of an individual relatively well. If you have, for example, a child who is 11 years old and he is in the bottom 1% of height for his age group, and you're worried that maybe he's not going to be tall enough when he grows up. In the US, it's becoming common for those kids to get hormone treatments, which costs the insurance payer $100,000 for years of treatment for that kid to take human growth hormone. But using the DNA technology, you can quickly determine that, well, this person is short right now, but actually when they're an adult, they'll be perfectly normal in height, and there's no need for these hormone treatments, and thereby you save the system $100,000. So the set of applications of this technology are actually kind of uncountable. We're still figuring out what they are right now. The figure to the right on the other side, the little black lines, indicates the places in your DNA that are influencing a little bit your height. If the little line points up, it means the genetic variant at that location is making you a little bit taller. If you go to another place and the line is pointing down, it means that the genetic variant there is making you a little bit shorter. And there are about 20,000 genetic variants that you have to take into account. Only the AI can do this. Humans cannot do this. You have to take into account these 20,000 plus locations in your genome, and only by aggregating their effects can you then predict the height of an individual. And this is the future for us. So things which AIs can understand well and make accurate and reliable predictions for, humans cannot really understand. It will probably take many, many decades, maybe 100 years, for human scientists to figure out what each and every one of those little dials in your DNA is doing that affects your height. So it's an interesting case study of AI looks at data. Once we get enough data, the AI can do something very significant with the data, but very hard for humans to understand it post facto. So for people who are here from government, let me just repeat the main point of this. Very fast advances in this field, similar to what happened to face recognition. We went from no ability to do face recognition to it's in your phone and it's free. Within just a few years. The same thing is happening here with genetic technology. If you're from government, you should probably figure out how to take advantage of it. Thank you.
Thank you, Steve. And thank you for giving these very clear, concrete examples. I think there will be more discussion on those after. Now I invite Lili to share a bit more on the Estonian experience.
Thank you. And thank you, Stephen, for the great introduction and lectures here in Tallinn yesterday and today. So, as a non-Estonian, I would really like to praise the Estonians for starting a population-based biobank and launching this whole process more than 20 years ago. And I joined the biobank about 9 years ago. And over the years, we've been doing these exact same studies that Stephen emphasized, really looking at all the genetic variants across the human genome and testing which ones are associated with what diseases. We're finding lots of discoveries, working with scientists from many different countries, and now building these kind of predictive tools that can, with the exact precision that Stephen described, then tell who are at high risk for specific diseases, adverse reactions from drugs, or no response at all to medications, and so on. So far in Estonia, we have recruited 200,000 biobank participants. That's about 20% of the adult population. And we are now at a point where we can start using this information in the healthcare system with a genetics-first approach. So we have piloted several studies where we use either very simple monogenic models, which means that you have a mutation in the breast cancer gene, you have a very high likelihood of getting breast cancer. So these are usually picked up by the healthcare system as familial cases of breast cancer. If your sister or mother gets breast cancer at an early age, the family members should all come in for screening. But what we learned from the genetics-first approach is that about 5% of the people with a mutation had been caught by the healthcare system. So these are sensitive topics that families might not talk about or share. And using the genetics-first approach, we were able to pick up a lot of mutation carriers with very high risk for breast cancers that are now going through the medical system for prevention and early diagnosis, which is much easier than to treat. We're currently also piloting these complex models with polygenic risk scores to see how we can use these in the healthcare system. And the preliminary data is very promising. For example, we see 2 times more breast cancer cases among people with a high polygenic risk score compared to the rest of the population. And for cardiovascular disease, we see 4 times more cardiovascular deaths among individuals in the top 5% risk category. So we now have cardiologists and oncologists who are driving this innovation in the healthcare system, and we hope to add on more and more tests as we go. And the last bit that we're working on now to get into the healthcare system is pharmacogenetics, which is the genetics of drug response regulated by hundreds of different genetic variants that regulate how quickly people break down different medications. Similarly to coffee, some people can have 10 cups of coffee in a day, some can barely have 1. And that's the exact same enzymes that are actually in our liver, breaking down commonly used medications. And about 98% of Europeans carry at least one genetic variant that affects drug response. That's why the current systems are more on a trial and error basis and causing a lot of unnecessary healthcare costs, burden on patients, while we have this genetic information in place and a €50 genetic test that can be used for the whole population to actually create better healthcare for all. And one topic I would like to raise regarding the ethics and the worries that we might have is that people who trust, they join the biobank. And a worry we have is that are people who trust going to get better healthcare? So we could have that point for discussion later. How do we reach people who currently do not trust as much as others?
Thank you, Lili, and thank you for raising that question. I look forward to discussing that more. Now, Dan will discuss with us some innovative models that they have at his company.
Good day, everyone. We see progress in healthcare, as showcased by Steve and Lili. We see increase in lifespans, but not necessarily in years lived healthily, meaning that sometimes at the end of our lives, we have debilitating diseases which can be hard to treat, causing strain also on the medical system. So what if we could avoid those early? The problem is that it's intractable to teach all the doctors and all the people about all the medical science that has been developed over time. And thus, this is a place where we can actually support the medical professionals with computers that look at data and help make better decisions. So I do have a slide or two, which I'd love to show. So I'm talking about a project which is intended to innovate how the kind of innovations that Steve and Lili marked on can be launched in a country. So what are the steps you need to take? In this particular project, we are building a data-driven clinical decision support tool to diagnose a rare form of asthma, severe eosinophilic asthma, which is pretty tough to treat if you're using the wrong drug. So one of the important goals of that tool would be to improve precision That's what precision medicine actually stands for. That we want to identify people who are suffering from severe eosinophilic asthma and start them with the right treatment. But this is not something that, for example, a general practitioner can detect easily. The other thing we want is efficiency. The governments would like to optimize healthcare costs because demographics, budget concerns, and all of that. So if we can reduce unnecessary treatments that have no effect, that also includes using pharmacogenetics, and if we can avoid the complications from treating something wrong until it becomes much more expensive to treat, then this helps the whole society because we can apply the right treatments for more people. Now, the design constraints around such a service are quality, because you want the best data for as many patients as you can. And while some countries do have a mature data infrastructure for health records, and so then some are still building. So it's important for them to do the necessary investments to reap the benefits. The second part is, as we also heard from today's plenary, there's the trust and the privacy issues. If we want to build that trust, then to convince the users the people to actually join these efforts, there needs to be a perceived balance of power. A lot of the service models we see today around data are very imbalanced. The user, the citizen, has almost no control over data, while the service provider has utter and complete control. If we could shift this balance back towards the citizen, then that trust might just increase. So the Estonian formula for innovation has been that in collaboration with the Ministry of Social Affairs, GlaxoSmithKline, an international pharmaceutical company, and clinical experts from Estonian hospitals and the healthcare agencies who are the controllers of Estonian health records, we have been jointly approaching the problem in a very holistic yet detailed way. So the pieces you need are a service model, good coordination, then the right algorithmic approach. How do you actually diagnose somebody or suggest that somebody might be at risk from data? You also need the clinical know-how. All this needs to come from the current clinical practice. We are using as an innovation privacy technologies that ensure that only the correct stakeholders, only the parties who need to access the data can actually do that, and there is no unnecessary cross-border transfer. And of course, there needs to be a will to do so. In this model, all parties are motivated. The government knows that this is necessary to control spending in the future. The clinical experts want to become better at their job. They want to teach new doctors to be more efficient. The pharmaceutical company knows that in order to be motivated to invest in new drugs for rare diseases, for example, these have to be diagnosed by someone. So they are also interested in pushing this. And as one of the foundation layers for Estonian e-government security, then it is our interest that the story continues and security and privacy are going to be related to the Estonian government. Thank you.
Thank you, Dan. Thank you for sharing this good example. And now we will have our last private sector speaker, Susan.
Thank you. Thank you, everybody. I represent... Thank you. I'll start over again. I'm from Modal Technology in the United States. We're involved in AI. We work with researchers in helping develop the tools to actually help make predictions and look for patterns. And what I wanted to talk about this morning is, we're involved with a hospital right now in Canada, a research hospital, and we're working on a project, and I'd like to talk about that a little bit, about what we're finding because of the technology. But also I wanted to talk a little bit about some of the barriers to having researchers become involved. You've heard some really good examples this morning of organizations that are already deeply involved in using AI. You heard this morning too at the plenary that there are a lot of organizations that haven't stepped forward yet. They know that they need to do it. Maybe they want to do it, but for some reason or another, they haven't started to do it. I believe that there's two issues here. One is fear. And part of that fear is the issue of ethics that we are all talking about and the relationship to patient good. People have lots of opinions about that. But the other issue is integration of two different scientific disciplines in terms of how, as a medical researcher, am I supposed to work with a data scientist, and how does that process work? And we've been approached by many healthcare organizations, and so we've designed a process, and it is a human process. It's a learning curve and a trust-building curve of understanding. We don't pretend to know the science, but we do know the science of organizing the data to help get to a solution. So there needs to be a common bonding of understanding and respecting the two scientific disciplines of medical research and data scientists, because the integration of those two sciences needs to happen almost immediately in the scientific process to optimize the solutions that you're going to get. One example was not long ago, a person who is head of the Regen Medical program for a very large hospital in the States told me that she thought that AI was a luxury, had a history of being around, not doing too much. And I said, well, what do you do? How do you look for information? And the story she told me was incredible. She said that she'd had about 3 years of data on a project, and she printed it all out, and she took a yellow marker, and she highlighted all the things that she thought were important, and she put it on the wall of the auditorium, and she stood in the middle of the auditorium and started looking for patterns herself. And I said, why didn't you ask for help? And so there was a process of hand-holding and trust building to say, now the next step is, let's have this conversation about what's your hypothesis, what's your goal, and how can we help you to make that happen. And one of the tools that we gave, and we've given this to several organizations, is I'd found a really neat flowchart that an MIT student did that said if you go through the flowchart and you answer these questions, you'll figure out if you need to use AI as a tool or not. And so I asked this woman if she would go through that process and make notes and tell me what she thought. And she did. And she said, you know, I really guess we do need technology to help us. And now I understand the thinking process of why I might need that technology. So having a process of allowing relationship building to integrate disciplines, scientific disciplines, I think is really important to the future here. On the other hand, the organization we're working with in Canada has two very visionary PIs, and they'd worked on this project. It's in oncology. It deals with liver cancer. They'd worked on it for several years. They hadn't gotten anywhere, and they decided that they were going to step forward and ask for help. We met with them, we built a relationship, and as a result of that, we've made some breakthroughs that they're getting ready to publish. I don't want to steal their thunder right yet. But the goal of the research project that we're involved in is to be able to, using technology, to identify disease from non-disease patients, and then being able to look at biomarkers that relate to the disease, and over 2 years track the patients to see if people are getting better. do the biomarkers change if they're not getting better? Do they change? Because the capability of the technology was able to print out the correlation of the biomarkers from the most correlated to the least correlated. So we're going to be able to track that. And then their approach is a little different in terms of starting with bed and moving to bench, of doing something good for the patient, and then being able to look and say, and because this is their goal, that as a result of that, we'll use the information to build a kit, a lab kit, because right now their testing is done by a mass spectrometer. And this would be not only better for the patient in terms of getting results faster, but also it would be more cost effective for the organization. So 2 stories, 2 directions. Thank you.
Thank you, Susan, for another good example of what technology is enabling in this field. And now I would like to invite our government representative on the panel to share his experience.
Thank you very much. Unfortunately, I'm the only government representative here. So I feel a little bit overwhelmed by all the scientific information, and I only started this job 1 month ago. But then again, I think it's good to share some thoughts on how we deal with AI in the Netherlands. First of all, thank you very much for inviting the Netherlands to the Italian Digital Summit. It's a pleasure to be in one of the most digital innovative countries in the world. And thanks to all the panelists for the inspiring presentations. In the Netherlands, we are developing currently an AI strategy. And we do this in a typical Dutch way, in a public-private partnership. We're creating a so-called Dutch AI coalition. So that's business, knowledge institutes, and government. And we'll be launching this strategy the 8th of October. But I can give you a little sneak preview today. I think we're trying to make a balanced story about reaping the benefits in the economy and society, and setting the right conditions for that, and also have ethical guidelines as a fundament for this strategy. And AI in health is a priority within this strategy, because like many countries, healthcare is a huge sector. It's 10% of GDP. So it's good to hear that some of the examples you gave can lead to cost savings in the system. And then the big question is how do we implement this? How do we get this? And how do we do that in a sensible way? And well, we're looking into this, but we're to give you an example how we're trying to do this now is by testing in practice. So in the Netherlands we have this is an example, a pilot called Eating Robots. We're not eating the robots, but the eating robots are helping elderly people to eat their dinner. And by putting that in practice, we learned that the staff who is next to robots need to be really well trained. It's really important to make it work in practice. And another example is in psychiatric hospitals, there are many situations of aggression. And there they applied machine learning on the video material to predict when patients will become aggressive, and then the medical staff and the doctors they can prevent their aggressive behavior and save a lot of money. So yeah, let's keep it at that. Thank you.
Thank you very much for sharing that experience, even after only a month. It sounds like the strategy is well under development, and in this, the talk about testing and practice, I think a lot of the themes we've heard in all the presentations also echo themes we heard in the plenary session earlier. You have to try things, you have to practice them and learn from them. And I think one of the quotes I liked is you have to respect those who try. And I actually thought that was a very inspiring thing to say and important to remind ourselves. But in any case, first off, I do want to thank everybody for their contributions, and perhaps I want to see if there are any burning questions from the audience. All right, not seeing any, then let me kick off the conversation. And I want to maybe get back to a theme from earlier about the speed of technology evolution and the gap between how the technology evolves, some of the positive results we're seeing, and how can we get adoption. And I want to ask the panelists at the table for any thoughts and suggestions you have on what are the right conditions or the right frameworks that need to be set to help bridge that gap. Any ideas? No.
Well, rather than give you constructive examples, I'll just remark that for people who are in medical research, there's a standard folklore that when something is coming out of the lab, even if it's a really great discovery, the typical timescale for it to get into clinical practice is over a decade. So, you know, it's very daunting to think that society could be so inefficient that something that works extremely well could take that long to actually begin saving lives and saving money. It's quite different from the tech industry, right? So I use the example of face recognition. There are many other examples, right? So I think the healthcare industry has a lot to learn from the technology industry. And I think probably the type of person who goes into medicine is very different from the type of person who goes into tech. And that may have something to do with it. Regulation may have something to do with it. It's really quite, I'm sort of new to healthcare because my background is actually physics, and it's only recently that I've gotten interested in genomics. So I'm actually trying to understand myself, how could it possibly take so long for a doctor who really cares about the lives of his or her patients to not understand and embrace some new developments which could really be of use. It's a mystery to me.
Yeah, I think a lot of it is about trust, and of course the practicing physicians have 6 years of training before they start acting, but I mean, research and technology is developing so rapidly, so I think it would be unfair to expect them to be on top of everything. So a lot of the treatment and a lot of the decisions that clinicians make are based on their previous training. And I think if people were genetically identical, the practicing medicine would be much, much easier. But unfortunately, we're not, or fortunately, we're not. And there comes a big part of why people maybe don't trust doctors always or their decisions. So what we see, for example, is that a lot of people who are prescribed medications actually don't fill the prescriptions. They don't buy the medications. And why is this? And with all the knowledge that I have in hand, I would probably not buy every prescription I'm given either before I look at my DNA. So we see that DNA and genetic testing could actually be one tool to increase trust in this area. And knowing that about 15% of people who get prescribed statins might get side effects and severe muscle ache, and this is very well known. And it's taking time for this knowledge to go from bench to bedside. So by now, about 100 medications actually have in the information sheet that prior genetic testing is either compulsory or suggested before prescribing this medicine. So hopefully, as these tools get more powerful, more predictive, more validated, they can be used much more broadly in the healthcare system and increase trust as we go as well. I think one part is of why the process is so slow is also that there is a lot of regulation around it. And the way we are trying to handle it in Estonia is that we're running a lot of the implementation as research projects. So we're testing implementation, and once we have the preliminary results, we'll move into next phases We're giving feedback and genetic counseling to biobank participants as a research project, because it's all research data, it's not medical data and so on. So in some places we also have to get very creative to see how we can solve these different issues. And I think Dan is also representing technology that hopefully will also increase trust, because when we get to genome data and all the health data of individuals, because the biobank participants sign a broad informed consent form, so we're allowed to use all of their diagnosis, all of their prescription data, and other health-related data coming from national databases and registries. So we need smart tools if we want to open this area up for private partnerships with public-private partnerships. Then we need to have tools that will keep the trust of all the individuals, that the data is stored securely, it's analyzed in a secure manner, without sharing individual level data and so on.
Thank you so much. I would love to follow up on that one. These innovation paths in medicine and technology, you might say that they're somewhat similar. In drug trials, you develop a drug, then you do a drug trial, and then you launch it on the market. However, when another drug comes along, then it needs to prove that it's more efficient. The efficacy is better than for the previous one. Now the question is that if a new drug comes and it is slightly less efficient, but also has significantly less side effects, the ones that we mentioned, the question there always that which is going to be valued more? And it's a matter of course, you can do it regulation and so on. But for technology, the innovation paths, sometimes they go differently. If you have a technology that, for example, is data-driven, then some choices you make with data, you cannot roll back. You cannot launch something new that is, for example, less privacy infringing, because if somebody has already used regulation to gather all the data in some way, and later you would like to introduce a new system that shifts the power balance and allows the same result with less data concentration, the question is, do you go for a new drug with lesser side effects? It's the same kind of analogy for data and privacy. A second challenge is an important one. Indeed, today, some of these projects are done under the research banner, and this is something that is perfectly fine as long as this is actual research, development, imagining the new models and finding good solutions. But when we say that now we are going into production, we are rolling out actual, let's say even potentially commercial offerings, if the private sector starts chiming in, then that will not be an available path for them. So there we will need new kind of approaches which resolve the concerns of research ethics, because research ethics boards apply to researchers, not so much to commercial companies launching services. So the new blueprint for commercial companies launching these data-driven services on very sensitive data is a matter of development for all countries.
Hi, does this work? Yeah. I wanted to ask sort of in terms of the state of play, and this is for Lili and Stephen primarily, I guess also Dan, in terms of, you know, you're talking about something incredibly disruptive in the way people sort of approach their health, which is some form of predictive capability through DNA or genetic sort of testing. And this, in countries like Greece, where I come from, is a very mysterious subject. You know, you've heard of startups like 23andMe, and some people have sent over samples, and you know, then they were sort of there was intervention from the U.S. government about their predictive sort of accuracy, etc. My question is, assuming the public sphere does not have the funds or the capability to actually properly invest, as you've done, Lili, in Estonia, is this something that you feel the private sector can responsibly do? Is it safe? Is it scalable? Is it something that can be properly developed even as a private service at this stage? Or are we some way away from a technical point of view, being able to offer this responsibly to consumers?
I think I can answer that very specifically. So already you are seeing some commercial direct-to-consumer genetics companies like 23andMe, Ancestry.com, MyHeritage DNA. They are starting to launch health risk reports based on the DNA sample that you send in. It is regulated in the United States, so there's a certain level of regulation. I think that you will increasingly, if you have a friend who's a doctor, say your next door neighbor, he'll say to you, I'm getting all these people coming to my office with these reports they got from 23andMe, and I know nothing about the science for how this prediction is done. However, the prediction that's done, that's implemented at scale by these companies, it's based on academic work. It's based on papers published in Nature, Genetics, et cetera, et cetera. It's actually much more rigorous than most of biomedicine. So if you actually ask what is the evidence for statins, the efficacy of statins, and you look at the size of the trial they did or this or that, the results that I'm talking about now in genomics are much more rigorous than that because they're actually being done by real data scientists who really know what they're doing. And the ends, the number of people involved is typically hundreds of thousands of people are being looked at to develop these results. So we have a strange situation where there will be commercial companies that may be able to tell you more about your health risks than your local physician. How is the health system going to adapt to that? It's going to be a difficult challenge, I think.
I would also like to respond to that I think there's two very important points here. One is that we need to demystify DNA. We need to demystify genetics. Like, currently doctors are using your cholesterol level, blood pressure, heart rate, like body mass index, and predicting your risk, and based on that, starting statins treatment, metformin, or whatever treatments, preventive treatments that are out there to prevent disease. So it's already there, it just gets much more precise if we add genetics. So persons with fairly low or medium-high cholesterol level that falls just below the high-risk group based on the standard parameters that are used, with high genetic risk, they should jump into the high-risk group. And this is what we're testing here. And the biobank participants that have received information, for example, about breast cancer mutations, they've done really nice narratives of this story, because what they say, and now there's several of them that explain this, in that they're saying that this risk was already in me. Now I'm aware of it, and my clinician can help me to work to prevent the disease from manifesting, or at least detecting it early, and thereby having much better treatment options. And regarding the aspect of public or private sector running such a project, I think one important point that Dan raised was that in academia and working in collaboration with the Ministry of Social Affairs, we are under very tight ethical scrutiny. So everything that we want to start implementing first goes through ethical review. So we're very conservative, it has to be actionable, there has to be proven benefit, and so on. And somehow companies can play by different rules. And the second reason why we want to run it as a state project is that it should be accessible to all. It shouldn't depend on your financial state. And the third reason is that we want it to be something that's integrated into the healthcare system. It shouldn't be a paper report or whatever you get from a private company and then walk with it to your doctor and ask, what am I supposed to do? So accompanied within this project is not only the genetic testing, but the IT developments are done within the National eHealth Foundation or the national existing health information systems. And there's training of doctors to participate in these studies and so on. So that's why we see it this way here.
I'm sorry, I just wanted to add one quick thing I should have mentioned. So the UK national healthcare system has already announced a pilot project in which they will genotype 5 million people in the UK and report eventually the polygenic scores of the type that I mentioned to their physicians. So there is at least one large national healthcare service that is actually pushing forward in this direction.
In addition to Estonia, you mean. I wanted to follow up on something else, and that's exactly the 23andMe case, because I've also heard about that one. Now, I'm not very familiar with this specific service they provide, but if I had designed that, I would have also added a remark to the bottom of that report that if you are a general practitioner, if you are a doctor, and you are confused by the document that the patient has brought you, then this is where you go to get the information. Or you can also redesign the service so that it actually engages and includes the doctors and general practitioners from day one, meaning that maybe these people would get referred to their doctors for interpretation. This demystification is a very important part here, and might be that the general practitioners will become the educators, but then again we need to teach them to be better.
Okay, so I see a number of hands up, so please go ahead.
Yeah, I'll just add to this final point. I'm from the Ministry of Social Affairs in Estonia, so I've also dealt with the project here on personalized medicine. The same issue about, is this something that the private sector might be able to chime in on? So certainly if you look at the Estonian solution, then we are working with publicly funded universities, and it's a centralized system. However, even in our case, we're not shutting the door to possibly including private companies into this. What is important is what Lili mentioned, is that you need to ensure that it's equal access, so there needs to be health equity, and that it needs to be integrated, so that it doesn't surprise doctors, it doesn't overwhelm doctors, and it takes into account the e-health infrastructure we have. As for costs, however, if you want to ensure equity, you're probably going to have to pay something for it as a government. I think I would definitely bring back what both Lili and Steve mentioned here, is that the costs aren't that high, actually. As a long-term investment, we do it 50 euros per patient, essentially, to do the testing and the analysis. So of course there's more you need to invest in, but it's not an egregious amount. It is more affordable than you might think.
Hi, my name is Thomas Mestra. I'm a physician from Norway, and I'm also have been running a precision medicine project for the last 3 years. And I think what my main sort of message here is that we should not, of course, underestimate sort of all the knowledge that is in these new technologies. But what we tend to overestimate is sort of how easy it is to actually have actions on top of this knowledge. And for example, this example, so if you look at the persons who are most risk in these polygenic risk scores, it doesn't automatically sort of say that we should know what to do with them. But on the other side of your graph, we have some persons who are on very low risk, and a lot of these persons actually get preventive medicine today, for example, like statins is a very good example. So my advice would be to actually start in the other end, because that would be also much more sort of sellable to governments and to the payers, because there you spend a lot of money on people who have actually a low risk, and if you start there, you'll have sort of an easy adaptation. But on the other end, where you actually need new interventions, we need to follow the old sort of rigorous way of actually finding out. And just one last point to Stephen. I mean, one of the things we shouldn't underestimate is here sort of the history of modern medicine. It's actually pretty short, and we don't need to go a lot of sort of years back to find large scandals where we have had medicine that we thought were sort of well functioning, rolled out to large patient groups, and then some years later we found out this had sort of huge side effects that made them sort of pull it from the market. So I think that's also something. I think there's a cautious approach would always sort of be to the benefit of the patient here.
I think one example that we could talk through a little bit, and there's a very good example of the pilot study that she already mentioned for this particular condition, which is breast cancer. So we're already familiar with something called BRCA, which is a particular gene, and women who have the dangerous mutation in that region can have significantly enhanced breast cancer risk. And for example, you probably all know what Angelina Jolie did as in a response to her learning that she was a carrier of the dangerous mutations. Now, we can, with the polygenic risk scores, identify women who are at similar risk to BRCA carriers. It's already well established what should be done medically, the standard of care for BRCA carriers, which is to, for example, start giving them mammograms maybe 10 years earlier than women who are not carriers. So now with this inexpensive technology, we can identify roughly 10 or even 30 times as many women in the population with similar risk to BRCA carriers, but who are currently unidentified. They're just walking around. And the standard of care for them, as a first guess, would probably be similar to what you would do with BRCA carriers. And her study, which I think she can tell you much more about, is sort of establishing that actually these polygenic risk predictors are able to identify women who are at super high risk for breast cancer. Now, your comment that the women who are identified to be super low risk, which we can also do now, those women you might withhold the mammogram that you ordinarily begin doing, and you save some money for your health system in their case. Now, I don't know how easy it is to sell to the woman that because of your genes, we are withholding this screening from you because we think you don't need it. Maybe you have a PR problem there, but I agree with you from a kind of rational cost-benefit analysis, that is the correct thing to do.
Can I just use 2 minutes on a very short story from our hospital, which really shows how difficult this is. So some years ago, we had, because the BRCA is a sort of really established sort of risk score for, or risk factor for breast cancer, and therefore, if you have had this sort of risk factor, you were in a lot of instances advised to actually remove your ovaries and your breasts. And in our hospital 5 years ago, we did that for 20 women. And the year after, we found out that the same sort of BRCA variant, genetic variant, actually was a sort of uncertain variant and not a pathogenic variant. And we had a huge, of course, we were sued. And this was a really, but mostly it was a tragedy for the women who actually got this surgery. And my question then, of course, I mean, your own sort of, I don't know if you have a wife or your mother, and if they came up with a polygenic risk score that was sort of developed 1 year ago, and you got this advice that you would now do this kind of surgery, what would be your advice? And I think this is really difficult.
I would be very careful about a surgery. I mean, that's a very aggressive way to treat it. I think that as a first step, I think, with fairly high confidence, just allocating mammogram resources, right? That's just screening. It's not damaging the person. That seems like a very easy first step, but we'll see how many years it takes before the systems adapt in that rather obvious way. I mean, an insurance company, when they figure out that you've been arrested for drunk driving, they raise your rates immediately. Okay, they can adapt to probabilistic inference seemingly much better than our healthcare systems.
Quick follow-up to that one. So if we go indeed to the whole surgery discussion, then I believe that if there is clinical practice in the hospitals, then the AI applications should support that clinical practice. In this case, I believe that it was not the computer that made the decision, it was the actual clinically reasonable decision to make. So what's the question of how you allocate resources and all of that? This is related less to the actual data-driven decision and more about how do you actually treat people according to the current medical science.
I think this is also one of the reasons we rather take a conservative approach. So we only take breast cancer mutations that are confirmed pathogenic that we use here. And of course, the polygenic risk scores for breast cancer are in a validation study to see how many times more cases do we see in the high polygenic risk group compared to the low one. And it's not going to be similar to BRCA1 risk or anything like that. So therefore, I think the treatment plans will be significantly different for these individuals. At least it will be earlier screening methods and more frequent mammograms and possibly some preventive treatment. But yeah, to keep trust, we stay conservative.
Thank you. And that was a really, oh, is that on the same topic?
Sorry, my name is Jaanus Pikani, and I want to follow up with this discussion here. Actually, I'm one person to blame because I was one of the initiators of Estonian Genome Bank, but I have also background of cancer surgery and a hospital manager, and want to bring it up that was Lili was mentioning that the genetic information what we are discussing is actually getting to be more like a normal healthcare and medical information. And that's why all the same rules that we have established and we have through the very painful lessons that we have learned through the decades that has to be applied. That's why we cannot actually cut the time and cut the corners that go and let the technology or the tests to the market or the medical practice without properly doing everything that is actually tested against the potential risks. And what was said that if we have slight risks that there might be harm your patients, but doctors are taught that don't harm, the first thing. Then you have to go through all these kind of clinical trials, all these stages when you get actually approved as a treatment or a test that can be used in the medical. And even then, in phase 4, we can find that there are some unknown complications. That's why we need to be cautious, but at the same time, maybe AI will help us actually to cut this time from lab to actually bedside. So this means that also we have seen this in clinical trial development and drug trials where we can cut the size of samples because we have more information. We can genetically specify and stratify the groups. So this is one thing that although we want to move quickly, we still have to be cautious and to be sure that we don't harm.
Yeah, I mean, of course, we should be cautious. We should assemble very strong evidence before we implement any actual policy. But I do want to say there's low-hanging fruit where what you're doing is not, there's no possibility of harm. It's just allocation of screening and testing. So, for example, hypothyroidism, we have a very strong predictor for hypothyroidism from DNA. And that's a very prevalent condition. Often people have it for 10 years and they don't realize because it's not standard to test for hypothyroidism until people reach a certain age. There's no possibility of harm from giving someone a hypothyroid measurement, thyroid level measurement, say 10 years earlier because they have genetic predisposition. So this is very low-hanging fruit. It's not risking anything. So I think you just need to be smart about these things. Secondly, when you talk about standard of evidence for making some policy or taking some action, if you demand only prospective prediction and then waiting a long time to see if the prediction comes through. So you say, oh, I will identify women who are young but they're at high risk for breast cancer, then I'll wait 10 years to see whether they develop breast cancer to verify my results. Of course, that's the gold standard. That's probably the best way to do it. However, in the modern era, we have data from countries all over the world. So once I build the predictor, say, on Estonian data, I can say, how well is this working in Sydney, Australia? And I just look at existing people who have already lived their lives, but I have their DNA from Sydney, Australia, and I see it's working perfectly in Sydney, Australia, it's working perfectly in New York City. How much evidence do you need? Do you really need to do a 10-year prospective study? I mean, you have to use your brain at some point, right?
So I think you are just trying to get into the open door already, because this is a general practice. Nobody is waiting actually this end point of the clinical trials that you have really clear evidence in the disease or mortality. This is, Kaplan-Meier curves and everything. So this is done already. Of course, you can do this more efficient, but there is tons of tiny factors like if you look genetics, this is what is a profile, genetic profile of this population, what you are using this. Is it applicable for different ethnic groups? This you have to prove. This have to prove. That's, of course, you can take it as a hypothesis, but then you have to prove this. But how you prove this depends on what is exactly. So you get a little bit simplified approach, I would say, because but anyway, in a clinical practice, If we agree some kind of rules, you have to play again. If you want to change a rule, you have to prove that this doesn't harm if you change the rules.
Of course, you're checking for how well the predictor works in different ethnicities. That's why you go to a different continent with different environment, people born in different decades, and you show that it's working in this other population. But that's different from waiting 10 years, right? That's very different.
I'd like to recognize.
Yes, thank you. I'm Kadri Sim from Institute of Philosophy in University of Tartu. And I wanted to ask the panelists, maybe broaden the discussion a little bit, because the title is AI in healthcare. We've been talking about genetics, which is great. It's a cutting edge thing. This is where the money is. But it's also clear from decades of research in public health that a person's health is mostly determined by factors that lie outside of the healthcare institutions, right? It's about your education, it's about your socioeconomic background, it's about pollution. This is the major part of what happens to your health, right? So I was thinking, so AI does not discriminate in terms of that, you can only apply to genetic information. You can obviously apply AI to all kinds of information, including this information that affects your health, but it's not a medical information in that strict sense as we understand it. So I was wondering whether, how do you see, how can AI be applied, made use of, and take into account this much wider sort of set of determinants of health? And made useful for people. Thank you.
You can get a lot of citations today if you publish a study that links data on genomes with data on anything else. So that seems to work. And collecting information from activity trackers or similar devices that track your life in various aspects of it, and then learn by combining a lot of that data together. It might actually tell us what are the driving factors. What's the nature versus nurture discussion. A lot of that work is already being done, and Lili will probably tell you for a couple of hours about it if you let her. But I believe that here actually collaboration and learning more will help in time.
Also in Minnesota, there's a project going on right now that's very insightful into what you're talking about, and it's looking at communities. And the test community right now is a semi-rural community, and it has a high instance of diabetes, obesity, and using technology to start to define the variables and then to make predictions to deal with community health issues. It's a whole emerging piece of new science, community health science in that respect. So I believe that we're seeing initial beginnings of it. There's a whole nother area of new science that's that is starting to evolve, and that's humans in space. And you're not going to be able to wait 10 years for some of those answers, because moon colonization probably will start in the next couple years. But the integration of technology and medical research is going to be paramount to sustain life and to intervene with health issues, not only physical health issues, but emotional and psychological issues. Do you want to be my hologram pal? Maybe something they talk about here in the future.
And I'd like to add to that question. So IEEE is working on a standard called Peace 7010 on measuring well-being metrics, recognizing that you need to measure more holistically. And this is in the context of a standard series on ethical considerations around AI and data implications and other related implications. So really to think about more big picture, what is well-being and how does AI or autonomous systems impact that? And of course, once you know how to measure that, you can then make decisions based on that. How do you want to act? What do you want to incentivize or disincentivize? And I saw a hand back there.
Yeah, I can see. Hello, my name is Daniel Tijink. I'm from Holland. And I also wanted to broaden the discussion a bit, because it's mostly cure we're talking about and not that much about care. You opened up it a little bit, but in care, care, also the example with the eating robot, we found out that, which was partly AI, because it knew when to work, when people talked, it did not come to inaction. But we also saw the surroundings were changing, so we did not really take that into account. So, for example, not the patients had another role, but also the care people who took care for him. And what we found out is they found it very important to get more autonomy, the patients, but the people who were taking care, they'd like to give care. So now the eating robot was taking a part of their work, and well, they were real kind of unhappy with that. So it's the main point is, so if you implement in a real situation something like AI, or then you also have to train people another way. You have to think about what does it mean for your relations. So it's not just a new solution a little bit, but it also affects surroundings and people who use it. So I'd like to have comments on this part.
Any comments? I think it goes back to the people first and people-centric comments that were made earlier as well. And we can't always anticipate all the consequences. So I think it touches on some of those.
So people first, but also the people other people who use it. So the question is, who is first? And so, for example, in this case, the people who took care were more afraid that something went wrong. And so they wanted to be assured by the managers if something went wrong, they were not thought to be guilty. But the patients were willing to have more risks. So all these things come up. So that's interesting.
Okay, one question.
Hi, this is George Diralis from Marathon Venture Capital, an early stage fund out of Athens, Greece. Since this room is mostly populated by policymakers, I have the following question for you, for the panel. What would your advice be for a country that aspires to become a player in this industry and wants to leverage genomics and precision medicine? Where would you start from? From collecting data or incentivizing startups or what?
It turns out that the DNA of people in Athens is just as valuable as the DNA of the people in Palo Alto. And so if you make the reforms in your healthcare system to implement population-level genetics, for example, which they've already started doing here in Estonia, you will create an ecosystem for startups that want to analyze that data. And so there is a relatively cost-neutral way you can actually bootstrap this kind of activity in your own country. This is actually what the UK is thinking, because their investments in this kind of thing have led to a huge number of companies that are trying to make use of the data now in the UK.
Yeah, and I agree with the comments both from the Netherlands and from Tartu that let's not focus only on genomics, let's broaden the discussion. But we can't overemphasize the importance of genomics even in nurture, even in your personality and preferences for care and a lot of many different questions. So that's why I would also definitely just second what Stephen said regarding recommendations, that especially now when genomic testing is becoming so affordable. So for a national project, you can totally manage with a €50 genetic test. It covers at least 700,000 common genetic variants and clinically important variants, pharmacogenetic variants, and so on. If you have a bigger budget, go for the $1,000 sequencing, get the whole DNA sequence. The added value there is that you'll identify a lot of rare genetic variants that could be like knockout mutations and very valuable for drug development and attract different pharma companies, for example. So there are examples of projects run in that way together with pharma companies. The UK just announced their €200 million collaboration with several pharma companies. FinGen in Finland has launched a project with pharma companies and so on. So there's a lot of valuable data, and we have to be very open about how it's being used to keep trust.
So one of the decisions to look forward is to how much of the private sector inclusion are you aiming for? Because today, a lot of this is international, as has been wisely said. There are genetic similarities in the populations around the planet. There are also some biases which would have to be factored for, but that's a separate question. There are today companies which are building AI decision support tools globally, meaning that they combine data from multiple hospitals in multiple continents, and it might just be that coming up with a nice regulatory framework for including them in your country is a way to go. That's one option. The other is to go for the governmental route and see whether this becomes an integrated part of the nation's health economy.
Just to follow up on the question where to start and why does it take so long to put these new technologies in practice. One perspective that has not been mentioned yet is the economic perspective. How are the incentives in the healthcare systems? So it's really good that you present here all the opportunities that are now available in science, but then to make the implementation faster, it depends on what kind of healthcare systems you have and who is benefiting from the implementation. And that's where you need to start from an economic perspective. Is it the hospital, or is it the insurer, or is it the government? And that depends always on the system.
Thank you. And as we are now going into lunch break, I want to be mindful of the time, and I want to thank all of our experts who had really deep expertise and information to share, and also thank you to the audience for engaging, for asking, for following up. And I think in the end, we heard all the opportunities that the technology brings, but I also think we need to acknowledge that the different sectors and the different philosophies and ethical approaches are ones that are being bridged in dialogues like these and in projects working together, like Susan was saying, of trust building, where that is a conscious effort that is part of the process of evolving these technologies and integrating them into all of the sectors in which we can benefit from these technologies. So the process that comes with it is work along the way, but I'm sure it will pay off in many ways. And thank you all for participating in it today. And please feel free to catch us at lunch and continue the dialogue. Thank you.